Intestinal obstruction can be described as a failure of the normal movement of intestinal contents in the small and large intestine, and it can result from various causes, including physical blockages and issues related to the nerves and muscles or blood flow. Neuromuscular problems can be linked to inflammation in the abdominal or retroperitoneal areas and are sometimes referred to as a lack of bowel movement. Pain from intestinal distension in cases of obstruction initially affects areas of the body supplied by the same somatic nerves. In the small intestine, physical obstructions can stem from different sources, including adhesions, scar tissue, and hernias, with adhesions being the most common cause. Simple small bowel obstruction typically occurs when an adhesive band constricts the bowel at one point, resulting in signs such as abdominal swelling and cramp-like pain. The buildup of fluid and air proximal closer to the beginning to the obstruction site leads to the dilatation expansion of the proximal bowel and the collapse of the distal farther from the beginning bowel. The pain associated with simple small bowel obstruction is cramp-like and located around the navel, often accompanied by audible bowel sounds. High small bowel obstruction can lead to vomiting, fluid loss, and imbalances in the levels of salts in the body. The level of obstruction can affect the severity of these changes, and severe cases may result in metabolic alkalosis, a condition where the blood becomes too alkaline. Conversely, low small bowel obstruction is less likely to lead to imbalances in salt levels. Strangulated obstruction occurs when the bowel is obstructed at two sites, leading to a closed segment. This condition is more serious because it can lead to complications like twisting of the obstructed segment and reduced blood flow, leading to necrosis, tissue death of the bowel wall, peritonitis, inflammation of the abdominal lining, and severe symptoms, including constant and severe pain, tenderness on abdominal examination, and changes in bowel sounds. Bowel necrosis can be detected through the presence of air within the bowel wall on radiological imaging. A lack of bowel movement, on the other hand, is characterized by the loss of intestinal contractions, leading to the accumulation of air and fluid in the gut lumen inside the intestines. It often arises due to abdominal or extra-abdominal factors, such as inflammatory processes in the gastrointestinal tract, the pancreas, or the biliary tree, as well as systemic conditions like severe infection, diabetic ketoacidosis, and severe injuries. Mesenteric ischemia can occur in acute or chronic forms and can lead to acute intestinal obstruction. The causes of mesenteric ischemia are diverse, including arterial embolism, blockage of arteries by foreign material, artery thrombosis, blood clot in an artery, and non-occlusive ischemia, reduced blood flow without a complete blockage. Arterial embolism can result from various conditions, while artery thrombosis is typically associated with narrowing of arteries due to atherosclerosis. Non-occlusive ischemia can develop in low-flow states, potentially leading to spasms in secondary and tertiary branches of the superior mesenteric artery, main artery supplying the intestines. The consequences of mesenteric ischemia can be severe, with rapid bacterial growth, tissue death of the bowel wall, and the release of enzymes into the bloodstream. The condition can progress to systemic infection and bacteremia, resulting in various clinical symptoms. Mesenteric venous thrombosis, another form of mesenteric ischemia, is characterized by the accumulation of fluid within the gut wall, mesenteric tissue that supports the intestines and peritoneal cavity. In summary, intestinal obstruction can manifest in various forms, and its causes and consequences can vary. Understanding the underlying mechanisms and recognizing the signs and symptoms is crucial for timely diagnosis and appropriate management.